What is up, y'all? Who's ready for another video on a patient with back pain? So today's lecture is going to be on disc herniations. Let me get this off to here so y'all can see the PowerPoint slide. Yeah, I hope everyone is doing great. I think we're rolling. We're good. All right, y'all. So let's dive right in. So disc herniations. First off, there is an example of one on MRI. So we talked in first video on a patient with back pain about muscle strain. Second video, spondylolisthesis, spondylolysis, spondylosis. Frog, I'm trying to make a video. Yes, we still have the frog making melodies in the background, y'all. We won't have this again, trust me, okay? So last 3 videos, we have the frog, but that's okay. Today though, disc herniation, with and without nerve root compression. Here's a herniated disc example, and let's dive right in. So normal disc here has your nucleus pulposus in the middle, your annulus fibrosus on the peripheral side of this, whatever you want to call this, is sitting between vertebral bodies, or on top of the vertebral body, right? And this is when it herniates, your nucleus pulposus will protrude through the annulus fibrosus and potentially compressing the nerve root, causing pain that goes down the limb. So this is commonly from degenerative process, aging, right? Nucleus pulposus becomes less hydrated as we age and weakens. And here we can see it will hit this nerve. One thing that's interesting to note is that it usually herniates posterolaterally, and that's when it compresses this nerve, because you have your posterior longitudinal ligament right here, anterior longitudinal ligament up here, posterior longitudinal ligament here. So it's kind of protecting it from herniating directly back against the spinal cord. Although that does happen and can cause worse symptoms, right, if it compresses the cord directly. So here's an MRI. So this is what happens, y'all. You have this weakened collagen as we age, reduced blah 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 genetic factors, reduced permeability, and mechanical factors, excessive or sustained loading, right? And then reduction of transport of all these things, nutrients, oxygen, metabolites. And then decreased secretion of proteoglycans. And then decreased hydration of nucleus, resulting in bad responses to loading. And then changes in loading and hydration result in more thick type 1 collagen, less thin type 2 collagen. Cross-links form between collagen, further limiting movement of tissue fluid, and this causes retention of damaged molecules, and that can lead to disc herniation. So this is interesting. As you lose, this is an MRI. You can see spinous process. You can see cerebral spinal fluid. You can see some spinal nerves. This is probably below the spinal cord in the lumbar spine. This is annulus fibrosus and nucleus pulposus. So this has fluid in it, right? Hydration. And that's why it's a brighter signal. This is a T2 weighted image. CSF is bright, fluid is bright. But as they age, there's less fluid. So you can see a darker T2 signal. Progressive disc herniation will occur here. Second most commonly from degenerative process, but second most common is from trauma. Herniation most likely occurs posterolaterally, as we said, where the annulus fibrosus is thinner, and it lacks support to the anterior and posterior longitudinal ligament. So those ligaments support this, but here it doesn't have that support, and it's thinner, and that's where it usually occurs. Lumbar spine is much more common than the cervical spine disc herniation, but if it happens in the C-spine, look for C6, C7. Lumbar spine, usually L5, L4, L5, L5, S1. So when you have a patient here, you're going to want to see what's going on with them, what's causing their back pain. So, going to want to ask duration, how long has this been going on? Could be acute, or it could be acute coming on from some chronic pain. Onset's usually sudden. The patient recalls an inciting injury due to either lifting, twisting, or bending. Usually there's no symptoms. Well, many instances there's no symptoms, right? And that's when you have no nerve root compression. This actually should say without or with. Ignore this up here. Because really we want to discuss when there is nerve root compression, because without nerve root compression there might not be any symptoms. But if you have nerve root compression, then you're going to begin to see some symptoms, some pain. But usually these things resolve in a few weeks. You know, within 6 weeks. Okay, the disc herniation will heal with proper rest and treatment. Usually, no treatment really necessary, I don't think. But don't take my word on that. So this kind of pain is usually burning, stinging, and it can radiate down the lower limb on the affected side of the disc herniation due to the compressed nerve root. You can start to see some numbness, sensory loss, tingling along the path of the nerve root. And this is unlike the previous stuff. I mean, this is nerve pain here. You're burning, radiating pains, electric shock, numbness, sensory changes, tingling. So be looking for that when you're thinking compression of spinal cord or nerve. Location, lower back. It can be in the buttock. It can radiate down ipsilateral limb, same side as the injury. So if it hits the right side here, it's going to be right limb. Aggravating factors: activity, lifting, worse when sitting, Valsalva maneuver, and cough. It can worsen as cough puts pressure on your vertebral column. So these things put pressure. They can worsen your pain and symptoms. Rest, of course, is going to help. You can have other symptoms with the back pain and butt pain. That can be radicular pain, as we said, down the affected nerve, sensory loss down the dermatome, numbness, hypoesthesia, right? Less commonly, you can have bowel and bladder dysfunction. Now, this is going to be more seen if this protrudes and hits the cord, and you get this saddle. What's it called, y'all? It's a red flag symptom. Saddle something. Oh well. Anesthesia. You just lose bowel, bladder dysfunction. It's pretty much just not a good thing. So risk factors, usually these younger people, 35 to 50, males, and proper lifting technique, as we saw in this picture. Where's the picture? Okay, where did my picture go? Oh, that was a prior video. That was on the muscle strain. But improper lifting technique, you know, you don't want to lift things with your back arched and stuff. That's not good. Repeated pulling, pushing, and twisting motions, trauma, or severe strain. And always ask your patient, as we always say, is there anything you are worried about this could be, right? Are you worried about this being cancer, tumor, or something more serious? You know, let your patient tell you what their concerns are. Don't let them leave your office wondering, hey, he never brought this up, we never discussed this, and I'm still concerned about it. I'm going to ask if they've seen other doctors for this already. So, before we move on, something interesting that y'all probably know. If this herniates at L4, L5, your L5 nerve root will be compressed. L5, S1, your S1 nerve root will be compressed. So it will be underneath, because the upper nerve root, I don't like this drawing. This doesn't show it too well at all. But yeah, you already know though. It's always the nerve root below the, L4, L5 herniation. It's going to be below L5 nerve. That L5 nerve root gets compressed. Physical exam. Okay, y'all. So you're going to have a positive straight leg raise test. Put your patient supine, elevate their leg, increasing the angle. Pain and paresthesia is reproduced. That sciatic pain reproduced. And you can tell if it's often L5, right? Herniated disc. So that's something you want to do. You can also see a positive contralateral straight leg test if the straight leg test, L5 or S1 root is compressed. Palpating the spine can show some paraspinal muscle tenderness. Again, you're not going to see, I don't think you'll see, never mind, I'm not even going to say it because I'm not sure, but you can note some paraspinal muscle being tender. Inspection of the spine is normal. Range of motion can be decreased. You will see root level neurological signs. So if L5 nerve root's been compressed, you're going to have sensory loss around down that dermatome, as we said. This nerve will go down into the thigh and leg, and you'll notice some sensory loss, maybe motor weakness, shooting pain, sciatica, reflexes are decreased. And then you're going to want to order, well, you might not, Well, I think you do. I don't know. These usually resolve in like 6 weeks, as we said. But if they're not resolved, you're going to want to do an MRI, X-ray first probably. But MRI really shows these nicely. Here's the herniated disc. Remember, this is dark. Why is this dark? So this is a T2 weighted image. Fluid is bright. And remember, when we go up here, this annulus fibrosis, I believe, is cartilage or collagenous. Okay, well, I don't know what this is, but it's going to show up dark on MRI on T2. So when this nucleus pulposus protrudes through here, you're going to push this dark annulus fibrosis into the nerve root. Okay, so that's why you see this dark thing. This is annulus fibrosis protruding into the spinal canal, hitting the spinal nerve root. You can see it on the axial slice nicely as well. It's dark right here. It's pushing into this nerve root. Really, this is possibly pushing into the, like right in here. You know, it's lateral though. You can see it's not like straight back, as we said. They're usually not. So that is the end of this lecture, y'all. This wasn't that bad actually. It wasn't that lengthy. So hope you all enjoyed it. And yes, keep watching, y'all. We're out. I'm not even gonna do this thing now because it's just kind of like, it just doesn't give the same effect unless I blow up my screen and then do it. You know. Anyways, see y'all later.